Hi, Dr. Dancer. It's so good to see you.
Hi, Dr. Alexander. It's always great to see you.
Yes,
Thanks for joining us today.
this is exciting. I always love doing these. It's fantastic, and the questions are always great.
There's a lot to learn and things change. So we're happy to have a good group here today.
Yeah, so I'll be doing the first part, and Dr. Dancer will be doing the second part of our talk, but we're happy to answer any questions at the end. And thank you to Brittany, our wonderful teammate, who helps us make the slides so beautiful and everything so nice. So today we're going to talk a little bit about preparing your body for IVF. So next slide. This is our team here. I'm from Los Angeles, born and raised, and I did a lot of my research on polycystic ovary syndrome and recurrent pregnancy loss. And I trained on the East Coast, but I'm a Los Angeles native. And this is my team, Ellie, Ariel, and Amber, and they're wonderful. And everybody here at SCRC puts a lot of heart into everything. Next slide. Dr. Dancer, would you...
There's our crew, not as big as yours, but we're eager to take very good care of our patients.
Wonderful.
Best crew I've ever had.
Yeah.
That's saying a lot.
They're so caring and dedicated. So next slide. So everyone here, all the doctors at SCRC have put a lot of compassionate care. We are proud of our lab here at SCRC that with over 25 years of experience, the surgery centers with us in one unit here. We have patients come in and out on the first floor to get ultrasounds and blood tests in the morning so they can jump in before work. We open at 6:30 in the morning. We're blessed to have offices also in Pasadena, a fantastic group of people working hard there, and a Santa Barbara facility with a full state-of-the-art embryology lab there too. And the pregnancy rates both here and there are really fantastic, and we work really hard and tirelessly to keep our pregnancy rate high. Next slide. What sets our lab apart, we have experienced and certified directors, double witnessing verification. We do the flash freezing or vitrification for both eggs and the embryos. And we do blastocyst biopsy up to the 7th day for PGTA testing and PGTM testing. And Dr. Dancer will go into the details on that. We do 24 chromosome genetic testing, sex selection. We have an EmbryoScope or time-lapse video analysis that does help us dive in deeper on which embryo could be better than the other to implant. And it provides information for a lot of us when we're trying to make these decisions with the embryology team to help our patients too. Next slide. So we're going to talk about preparing your body for IVF. I always say it's like preparing for the Olympics. You want to get as healthy as possible. Talk about the patient evaluation, the egg retrieval, the IVF process, embryo development, a special offer, and any questions. We're happy to answer any questions. Next slide. Yeah. So what are the benefits of nutrition for fertility? It really is that food is our medicine. You know, thinking about colorful fruits and vegetables is very important. Folic acid prevents spina bifida. So it's important or if you're thinking about trying to start a family, maybe in a couple months or in 6 months, it's very important to take folic acid or have a prenatal vitamin. Vitamin B12 goes down with metformin. So some of our polycystic ovary patients are on metformin, and so they may have B12 deficiency. And it's important to have omega-3 fatty acids, especially for sperm quality. We're noticing wild-caught fish is a little better than farm-raised fish in terms of choices of our nutrition. It's important to think about, there's some evidence with walnuts and trail mix and just having the healthy fats in our diet. We encourage, all of us here encourage the Mediterranean diet, a plant-based food, whole grains, vegetables, fruits, nuts, seeds. It's important just to have a well-balanced diet. Some people ask us about intermittent fasting. There are times where we discuss it, but occasionally it kind of shocks the system, and the hypothalamus and pituitary get a little startled when we do these long fasts. So it may be good and bad for some individuals. So it's everything in moderation is ultimately the key. Next slide. In terms of prenatal vitamins, a lot of patients ask us, if you really want to have a good prenatal vitamin as you prepare, it should have the DHA or the fish oil, which is pregnancy safe fish oil. It can be plant-based if we're vegan. And the prenatal vitamin is very important, as well as CoQ10 or ubiquinol has evidence that it improves the mitochondria, which are the part of the cell factory that gives energy to the egg that helps us get the embryo to develop better. CoQ10 has evidence to decrease inflammation as well. And so that can improve if we have hidden endometriosis. And so it's important to think about CoQ10. It also has been shown to improve sperm quality, as well as vitamin D has anti-inflammatory properties. And we're really trying hard to get the vitamin D level 30 to 50 for both women and men for fertility benefits. And I feel like since I tell patients all day to take vitamin D, I just put it with my toothbrush, I take the D, and it really does have health benefits. I feel like it's been helpful to take it. Next slide. It's important to think about toxins, everything in moderation. So some people really get so stressed out. What have they done all through college? They, enjoyed time and partying and this and that, but we can't really look at the past. And I always tell people just look to the future. I know Dr. Danzer says that too. Like all we can do is sort of look forward for things. So it's important to avoid excessive alcohol or binge drinking. There are papers that show if we have more than 4 drinks per week, there was a lower live birth rate with IVF. So it is valuable in that month to 3 months preparation to really try to avoid, especially hard alcohol. Interestingly, sperm is impacted by 72 days of exposure. And so in men, it's important to talk about marijuana, CBD oil, as well as women. We don't have as much clear data on egg quality with it, but we do have some papers about cannabis and CBD oil and vaping. And the vaping tools have minerals and metals and things that are not really good for the microenvironment of the egg or sperm. Tobacco has long-standing been known to cause earlier menopause. We don't like the word, but it's earlier change in our life of our hormones. And so it's important to really think it through if you've been smoking, to think about, consider Chantix or talk to your primary care doctor about other options and ways to lower tobacco. It also impacts sperm motility, and so the sperm aren't as fast with smokers, and so it's important to think about that as well. Next slide. So the benefits of acupuncture, I know when I was trying in my later 30s too, I really found it beneficial to do acupuncture. It improves sleep, reduces stress, improves blood flow to the ovaries. It in some of our patients with really bad nausea with early pregnancy, we see some benefits with acupuncture. There's evidence that you feel also less cortisol rise and fall, which is our stress hormone, especially in our polycystic ovary syndrome patients. The adrenal gland kind of is producing more DHEA and DHEAS than usual. And so it could be beneficial to think about acupuncture. I know Dr. Danzer does the most beautiful embryo transfers, but on the day of transfer, some people find it valuable or calming to have acupuncture prior to the transfer. Sometimes if patients say they don't love needles, they feel stressed to think to do something like that, we just respect that and think about it. It's just a tool that we use to talk about when we talk about how to help you along your journey through IVF. Next slide. In terms of what is infertility, so it's really important to think about this, but you really have to have regular menstrual cycles. So if someone is saying 6 months, no menstrual cycle, that's different than when someone has a regular menstrual cycle where we're hoping and assuming they're ovulating. But when we're under 35 and having regular periods, if you've been trying to conceive for a year, that's the definition of infertility. When you're over 35, the chromosomes in the egg start to get a little bit different, and there's a higher risk of aneuploidy or chromosome problems. And so really after 6 months of trying, it's important to dive in deep and look into why this might be happening, try to evaluate the situation. Next slide. Natural ovarian aging is part of life. I think it's always beautiful to think that when we were a baby inside our mom's tummy, those eggs, your ovaries were being formed. And so even toxins, environmental pollutants, plastics, things we don't really know for sure about that maybe impacted our mom when she was pregnant could have impact for ourselves, as well as, of course, genetics like Fragile X, Turner's syndrome, Turner's mosaic. There's different things that could be impacting that. But in terms of the ovaries, we're born with our eggs, and as time marches on, the egg quantity changes. Patients always ask, how do we improve egg quality? Well, we don't have any specific things. We talk about lowering stress, acupuncture, nutrition, vitamins, exercise, mindfulness, yoga, really trying to just empower ourselves to be as healthy as we possibly can. And the other thing that is beautiful is that every month when you're ovulating, that egg has the chance to be a healthy egg. And so I try to think of it in a positive light, even as an older parent. And as we get older, there is an opportunity for us to look into that. And Dr. Danzer will go over the details too. Next slide. In terms of AMH or anti-Müllerian hormone, a lot of people ask, what is that? That's a hormone produced by the granulosa cells around the egg. And that hormone is used as a guide to understand a little bit about our egg supply. It's not a perfect test. And if we've been on birth control pills for a long time, like since age 16, been on birth control pills, sometimes it can be falsely suppressed with the birth control pills. But generally speaking, it's a little bit of a red flag if AMH goes below 1 at any age, anytime. But in general, depending on your age range, we have targets of where we want the AMH to be. And we never trust one viewpoint. We usually reevaluate it to get a sense on it. And so it's important to kind of, sometimes patients are told, or modern fertility or these tests at home, that their AMH is really worrisome and bad, and they come in crying and they're really stressed out, and then we recheck it and it's decent. So it's a little bit confusing for some people, but in general, AMH is used as a tool to understand supply. It doesn't reflect egg quality necessarily. The day 3 of your period, or second to third and fourth day of your period, we can check a hormone called FSH, follicle stimulating hormone, as well as estradiol. They go hand in hand for us to understand your egg supply as well as egg quality. And that level can ebb and flow month to month. But if it is above 10 for the FSH, it's also a little bit of a red flag that the egg supply and quality may be shifting. And so it's important to talk to your doctor about how to improve that, what we should do, make an action plan, and have a strategy ahead. Estradiol is kind of interesting. As we get older into our 40s, for some reason, when we start the menstrual cycle, the estrogen can rise quicker than we would expect. And that can be because a lead follicle or a follicle is recruited. And when the estradiol is high, it also can make the FSH go down. And so that's the yin yang of FSH with estradiol. And it's important to talk it out and think it through to try to optimize the group of eggs so that we can get the best quality egg to ovulate that month. This image is a beautiful image here on the right of the ovary, and we see the little follicles, which are each little circle there. It looks like a chocolate chip cookie. Each circle has one microscopic egg. Those follicles are called your antral follicle count. typically we're hoping to see 5 to 10 on each ovary. Sometimes some patients come in and have 2 on each ovary. It doesn't mean next month you would still have 2 on each ovary. Sometimes the following month we'll see 5 on each ovary. And so it can ebb and flow. And that's where exercise, acupuncture, improving blood flow to the ovaries can help, as well as vitamins, proper hydration, and things like that can help that. If we do see a lower follicle count, it's important to talk about the protocol and which IVF strategy you want to do with your doctor too. Next slide. I'll pass off the baton. Thank you so much. Thanks, Dr. Danzer.
Great presentation. Thank you. So before we get in the presentation, just want to give you some information about SCRC, Southern California Reproductive Center. We've been here for 23 years. We have 6, 7 doctors. Experience makes a difference in terms of success rates. Certainly a laboratory, and we're probably the second largest IVF program here in Los Angeles area, able to do more than 1,000 IVF cycles per year. And that's important for us, the rhythm of the laboratory, how well they do. We have a good group of embryologists that are very well trained, and we're able to monitor the success of each embryologist. So experience is a critical factor in terms of giving the very best treatment and the best success rates for patients. Just want to go over just for a minute, male testing. So one of the very first tests you do for fertility is have the sperm source do a semen analysis. And again, they look at the volume of the semen specimen, but more importantly is the concentration. You like to have greater than 20 or 30 million sperm in what they call it ml or a cc. So the concentration is important, but more importantly is the motility and how well those sperm swim. And that's important because sperm, don't have any eyes. They can't see the egg. They have to move around rapidly to find the egg. And also that motility is important in burrowing through the outer coating of the egg to fertilize it. So we talk about orsal morphology. Probably 80% of 90% of the sperm are abnormal shapes, small heads, giant heads, double tails. The testicle is making millions of sperm every day. Sperm are different than eggs. Women are born with their eggs and they begin to get sticky chromosomes as they get past age 35. Men have brand new sperm every day. And age 45, you begin to see some increase in autism and the offspring of men in that age group. But generally the motility and the morphology, the sperm count holds very well for men in their 40s and up into their 50s. But again, if we see lower motility, IUI, intrauterine insemination, is one of the treatments that is used. And what they do on the day of ovulation, get a sperm specimen, and it goes into a kind of a protein gradient that picks out the best swimming sperm. That's only the highest quality sperm motility-wise that's able to find an egg and then burrow through that outer coating and fertilize the egg. So that's what the laboratory preparation is for IUI. Pick out the best swimming sperm and also the best shaped sperm. And then those few drops of the very best sperm are placed inside the cavity of the uterus, which is done with almost like a pap test. It's very simple. It takes literally 5 minutes and women get up and go about their regular activity after that. But studies are very clear that using the IUI when you're using fertility medication does improve the pregnancy rates. And that's been shown in almost all the studies. So our next slide is a way of testing. We don't have a really good test for sperm physiology and their ability to fertilize an egg. We look at how they swim and their count. There is a test that looks at their DNA fragmentation rate. It's a little bit controversial about how well it describes the fertility potential of sperm, but it's used in certain situations where men have lower counts. or lower motility or high morphology. And you can see that we know that men that have abnormal DNA fragmentation of the sperm tend to have a higher pregnancy rate. You can see on that far right where they inject the sperm into the egg. That gives you the highest pregnancy rate for men with lower counts and motility, and those that tend to have this problem with this DNA fragmentation. But the technology is changing that. There's a new filtration technique called Zymot, and is very promising in that it shows we have a higher pregnancy rate with men that have these problems with lower counts and motility. It tends to select out the very best shaped sperm, and pregnancy rates seem to be higher, fertilization rates seem to be higher. So the field of fertility treatment is changing all the time. There's a great amount of technology that's coming into our subspecialty, and we at SCRC have always been committed to embrace that higher level of technologies. One of the first things we talk about IVF that everybody says is, what is this egg retrieval timeline? How long does it take, and how do I work around my work schedule and travel schedule and weddings and birthdays and the holidays? And so the treatment end to end is about 2 weeks. It takes about 12 to 14 days to mature an egg. You have to have a mature egg to be able to retrieve it from the ovary and also to fertilize that egg. So again, women ovulate day 12, 13, or 14, so it takes that long to mature the egg. So to improve the numbers of eggs we have to retrieve, we use injections of follicle stimulating hormone. It's the natural molecule, does not have any side effects. The only thing it does is bring to maturity would-be wasted eggs, because basically the ovary wants to release a single egg. Humans don't have litters, they just release one egg. Whereas with IVF, we tend to use birth control pills for the first 2 weeks after period starts to get the ovary quiet, to synchronize the follicles. So then you start the injections of the follicle stimulator, you tend to get more eggs for retrieval. Again, millions of women have taken injectable FSH. There's no breast cancer, ovary cancer. The only thing it does in the body is bring to maturity would-be wasted eggs. Because most women are going to have somewhere between 5 to 10, 15 to 20, or 30 plus eggs when they start. But normally only one is released and the others are wasted. So again, with the injections of follicle stimulator, you're able to bring to maturity a greater number of mature eggs. So once you retrieve the eggs, and they're in the laboratory to grow for about 5 days to the 100 cell stage. You can see on the next slide, as Dr. Alexander showed you that picture of the chocolate chip cookie, that's the start time. And you can see there's about 10 follicles in this one ovary for this woman, which is great. And after the 10 or 12 days of stimulation, now these follicles, instead of being 8 to 10 millimeters, are up to 18 or 20. And then most of these large follicles then have mature eggs. So that's again, the goal of IVF is to mature as many eggs as possible for the given follicle count for each woman. And so the needle goes just like 1 inch into the ovary, into the follicle. You aspirate the fluid, then you go to the next follicle. And then the fluid is collected in a test tube and goes into the laboratory. But you can see this needle puncturing the ovary. Again, during the procedure, it takes 15 or 20 minutes, depending on the number of eggs. They have a very light anesthetic, propofol. Most of the time, you wake right up afterwards. I've had it several times for dental work, and you're out the door in an hour, hour and a half. So it's a very safe procedure. It's if you don't feel any pain when there's the needle is put in the ovary, and most women are able to take Tylenol to manage their pain afterwards. So we can look on the next slide. And here's an egg under the microscope that's magnified about 100 times. And you see this needle going into this egg, which is like jelly. And by placing one sperm into the egg, you optimize fertilization. Again, as we mentioned, we don't have a really good test for the ability of sperm to fertilize an egg. And you do see when you put sperm and egg together in the laboratory, if they don't inject them, sometimes the fertilization rate is very low. So ICSI, intracellular sperm injection, is sort of the rule today. It optimizes fertilization. It doesn't damage the egg. Like I say, it's jelly. And probably 90% of IVF today is done with intracellular sperm injection. It's very safe. You see the needle going in, but the ovary, again, is jelly and it just pops back when they remove the needle. But again, you put a single sperm in the egg, you don't want to over fertilize it and you don't want to under fertilize it. So once the sperm has been injected in the egg, then we watch it develop in 2 cells, 4 cells, 8 cells, and then it grows after 5 days to this 100 cells, what they call a blastocyst. And at that point, we have placental cells in the center or around the outside, and the fetal cells in the middle. And this is what they call a biopsy stage, where they can take several placental cells. You don't want to biopsy or take fetal cells. And then the embryo is frozen, and they send the cells off, and it takes a week to get the genetic testing back. But again, this is what all of us looked like way back after conception. You know, it's a miracle every time. And again, we were looking for the genetically balanced embryo. It could be 1 in 3, 1 in 2 when you're 35 or under. But when you're 40, it's 1 in 4 is genetically good. So this next slide just shows how they take several cells from the embryo, and then those cells are sent off for genetic testing, which takes about a week. But at that point, for this blastocyst, this 100-cell embryo, it's frozen at that point, and we know the thaw rates are close to 99%. So you don't lose embryos when you do the freeze and the thaw. But that, again, that allows the body to recover from all the stimulation process, and then the transfer of the embryo is usually about 6 weeks after the retrieval of the egg, because again, it takes time to get the genetic report back to select out the embryos to transfer, but it also lets the body recover from all the stimulation process. So here's looking at pregnancy rates, and again, it's a little bit busy slide, but if you look across the bottom, no genetic testing, you know, pregnancy rates are, 45, maybe 50%. For young women, there may be 25% when you're over 40. But once you do genetic testing, it almost doubles the pregnancy rates. Because again, as we mentioned, when you're under 35, 60% of the embryos are genetically good. When you're 40, it's 25%. So the purpose of the genetic testing is to select out the embryos that are genetically balanced. And by balanced, we mean one chromosome, there's 23 chromosome pairs from the sperm and 23 from the egg, and they have to reassemble, and there's thousands of genetic pieces. So we're looking at that reassembly with the genetic testing, which allows you to select the very best embryos for transfer and the highest level of pregnancy rates. So we do very well with this at SCRC. You can say we have a very experienced laboratory. We offer what they call the EmbryoScope, which is live monitoring of embryos as they grow. We know that embryos that don't grow symmetrically in the first few days after fertilization, the pregnancy rates are half of those that go 2, 4, 8 cells. So you want to pick the embryo that is symmetrically dividing from the very beginning. It helps to rank the embryos. So you transfer the best embryo first, then you don't have to go through 3 or 4 embryos that have the very best chance for pregnancy. You want to select the very best embryo with the greatest potential to transfer in the beginning. And for couples that want to have 2 or 3 kids, what do you have embryo-wise that's going to allow you to have that second or third pregnancy? So EmbryoScope with ranking of embryos helps you make that better decision. if you have a lower number of embryos, then you might select to do another IVF cycle to get another group of genetically balanced embryos. And again, here's looking at national averages. That's the kind of the orange line. And this is SCRC at almost every age group. We're able to get higher pregnancy rates. And certainly a lot of that has to do with the quality of embryos that you grow in the laboratory. And that has to do with the experience of the laboratory. And also with the embryoscope, which helps us, again, to pick out the best embryo to transfer first. So again, here's our team of fertility specialists. Almost all of our doctors have been here for at least 5 to 7 years and done thousands of IVF cycles. And again, I think the experience of the doctors in the laboratories is what provides the best opportunity for you to be successful in terms of your fertility journals. So I think we have specials. We do this different times of the year. Post-summer, a lot of couples are getting ready to do their IVF, or young women are back from summer and ready to do egg freezing. This is time where we offer these specials. And we know that age is really such a dominant factor in terms of our success rates for both men and for women. So I think we're at the question and answer time. If you want to put in your questions, Dr. Alexander and I will try to answer those questions for you.
I know a lot of people ask how they feel on the shots during the 10 to 12 days of injections. Some people feel breast tenderness, headache, mood swings, thirsty. It's important to stay hydrated and take a walk every day. We recommend limiting jarring activities just to avoid the ovaries from, heaven forbid, kind of turning on the blood supply. And it's important to just stay as hydrated as you can and avoid constipation.
Some women feel great on the estrogen. I was just talking to someone this week, says, well, I feel better than I ever have. So that rise in estrogen, there's that 15 or 20% that feel really good with that high estrogen. And, there's a 15 or 20% that begin to get that high estrogen side effect. But most feel really pretty well during the procedure. It's only that last week when the estrogen really starts to rise that you tend to have those side effects. Everybody, most aggravating symptom is bloating, which goes away fairly quickly after the egg retrieval when the estrogen drops.
Yeah. I see one of the questions, how involved does your partner have to be? Well, when COVID hit, we didn't have as many partners coming into the office as much, just to limit kind of the flow through the system. But we definitely need a semen analysis. And like Dr. Danzer mentioned, the sperm DNA fragmentation in some situations, we'll discuss whether that's good to order or not. And then we need the sperm on the day of the IVF egg retrieval. But otherwise, depending on their work schedule, some partners want to come to the visits and talk things out. And sometimes they could be on video during the consult, not necessarily in person if they have limitations with their time. And some men who travel freeze sperm. If the semen analysis is normal, we've been finding that frozen and fresh sperm are equivalent success. So it's a good thing to think about. Or if someone has erectile dysfunction and is really stressed out for the day of the egg retrieval, it can be really helpful to have a frozen sample ahead of time so there's less pressure that day.
Yeah, during the cycle, you always tell them that you want to have a partner that's sort of the cheerleader. Sometimes they do the injectables. But yeah, it can be a bit of a bonding experience. Absolutely.
Just reading the other questions. I don't know if you want to, someone. Oh, they asked what's the age limit for egg freezing? Well, we had our ethics committee meet and we are still freezing eggs into their 40s, but and the survival of the thaw of those eggs has been hit or miss for some patients. But what's important to recognize is the genetics of the eggs really starts to get more difficult after age 40. And so it takes a lot of eggs to get the golden egg to get a healthy embryo. And so we've had patients in their early 40s have a few eggs and thaw them later and get it at pregnancy. And we've had people thaw the eggs and they don't make an embryo that's healthy. And so it's important to understand that an embryo will always be better than an egg when you think about freezing or preserving your fertility for the future when you're in your 40s. I'd love to hear your thoughts, Dr. Danzer, too.
Yeah, the advantage of genetically testing an embryo, again, in untested embryos, the pregnancy rate is probably half of what it is for a tested embryo. Again, depending on the age, but so many of our patients are late 30, early 40. And again, genetically balanced embryo tells you what you have. If it's genetically balanced, the pregnancy rate is 65, 70%. But you don't want to transfer embryos that aren't genetically normal. Miscarriage rates can be 20 to 30% if you're 40 years old.
One of the questions says their FSH was 24 high, and the goal for FSH is to be below 10, around that if possible on your period. Sometimes we can gently suppress the FSH with estrogen, but you would talk about it with your doctor, and that is done the week or two prior to the period. And interestingly, occasionally the follicles listen to the medication, which is called FSH as well. The hormones we use to grow the eggs can be utilized, called FSH as well. And so that can be helpful to lower the FSH prior to the anticipated period. And we do see some patients who say they never recruit the follicles a little more synchronously or together. One of the questions on that question was how to naturally reduce FSH. There isn't any specific vitamins or anything to lower it other than stress reduction, acupuncture. Sometimes a hormone or vitamin called DHEA can be helpful, but you want to make sure you're up to date with your pap smear and mammogram and talk about it with your doctor, because some people can have some side effects with it.
Great explanation. Thank you.
A patient asked, can they use donor sperm to fertilize the eggs? Yes, that's important to keep all options open and discuss it. It's to pick a good sperm donor, you really want to have some blood tests done to check on your own genetics and things like that to make sure you pick the optimal sperm donor. But talk that over with your doctor. Do you want to answer this one, Dr. Danzer? How can you start the IVF process if your partner has azoospermia?
Well, it'd be important to determine why. Azoospermia means there's no sperm on the semen analysis. And again, that can be a blockage. And so there would be a referral to a specialist, an andrologist, who is a urologist who specializes in male fertility. And they would do the test to determine if there's a blockage and that there's normal sperm above that, or what is the reason for the low sperm count or no sperm, and how that might be treated. But, it can be obtained from putting the needle into the testicle, what they call TESI, testicular biopsy. Because I want to say many times, but sometimes there is actually sperm production at a low level inside the testicle when there's no sperm in the semen analysis. But again, that testing evaluation is done by an andrologist, and the andrologist comes here to our center and can retrieve sperm from the testicle itself.
One of the questions was talk a little bit about PCOS in women over 35. Polycystic ovary syndrome is caused by genetics. So from our parents, sometimes there are certain polygenetic genes we can carry, as well as environmental pollutants and toxins that nobody understands. But some people think there is factors out there and endocrine disruptors that are influencing polycystic ovarian patients. But basically, it can cause high testosterone or male hormone, which can cause us to not have the environment around the egg to ovulate a mature egg, as well as the LH pulsatility from the pituitary kind of is going at its own beating drum. And that can disrupt the LH surge, which causes the egg to be extruded from the follicle. And so as we get older, some patients with PCOS can have be slim, it can be overweight. So there's different phenotypes of PCOS. Some patients have hirsutism or hair growth where it shouldn't be, and male pattern hair development or hair loss. Some people have a higher risk for cholesterol problems or cardiovascular risk and type 2 diabetes. But as we do get older, the interesting thing with PCOS is there's more eggs than average, but the quality can be a little impacted by inflammation. So it's important to take vitamin D, keep your hemoglobin A1C or insulin resistance under control. Exercise is really important to keep your body as healthy as and prevent preeclampsia in pregnancy, as well as gestational diabetes. But in terms of the ramifications over age 35, age, as Dr. Danzer showed, was the biggest factor in impacting IVF success in terms of egg genetics and quality. And so, and there are some vitamins that are helpful with PCOS, but you really want to talk it out with your doctor too. You want to do this one, Dr. Danzer? How do you compare different embryology labs?
There's several ways to do that. Here at SCRC, we have a full-time PhD level embryologist, also has a master's degree in genetics. The smaller laboratories may not have a full-time PhD. So I think that is one kind of crucial factor in how a laboratory is monitored and offers the highest level of I want to say growing the embryos to an embryoscope, which we were one of the few programs in the city that has an embryoscope to grow embryos and watch their development and how symmetrical they are. And again, that takes a PhD level person to offer that kind of testing. You can look on the SART data, which is the Society for Assisted Reproductive Technology, and they will list your pregnancy rates. There's a lot of problem with SART data in that it's the reporting and the follow-up is difficult, and it's very complicated. I think people that look at SART kind of come in every once in a while and mention that. And it's I think it ought to be simpler, but that is the national sort of database for the pregnancy rates for given, I want to say, laboratories or IVF programs. I don't know if that answers your question completely, but do you have any other thoughts, Carolyn?
Oh no, that was right. Yeah, I think, I'm really proud of our embryology lab. I feel like we're always super communicative and all together and discussing ways to improve outcomes for patients.
And there's a monitoring for embryologists. They look at how embryos grow and they look at, and we have one embryologist that goes all the way through from egg retrieval to fertilizing and placing them in the incubator. There's no handoff. You don't want to hand off any embryos or sperm. It's all done by one embryologist. And we have a second embryologist. We have enough to do that verifies the identity of the sperm and the egg, and it stays with one individual with a second person monitoring them. So there's no mistakes in the laboratory. And I think that's, critical too. Smaller programs or some bigger programs, we read in the paper every once in a while, there's a mix up. Luckily, that's very, very rare in IVF today. But again, in our laboratory, we are large enough that we have two embryologists verification of every step along the way. There's never a handoff from beginning to end.
One of the patients asked again about age 43 and egg freezing, because it's a big discussion with your doctor about egg freezing versus when you're single thinking about using a sperm donor to fertilize some of the eggs. There have been cases where it does take a lot of eggs to get a healthy embryo. And so it's a little bit hard to give exact statistics. We did look here at our embryology lab for 37 years old, we needed 17 to 20 eggs to get a pregnancy. And I know my colleagues on the East Coast have all these graphs and tell patients, but sometimes it feels like, how are you possibly going to have at 43, 30 eggs to freeze? Because on average, we see maybe 5 to 10 potential eggs. Sometimes we'll see more on some individuals, but it usually to keep you safe through the process as well as prevent hyperstimulation syndrome, but we're trying to get as many eggs as we possibly can in that cycle. And so there isn't a perfect answer to your question about age and the ramifications for egg freezing. I think the challenge is it takes a lot of eggs to get a healthy embryo ultimately.
We just don't have a lot of data on that. There are databases out there you can Google egg freeze, Brigham's Women's Hospital egg freezing calculator, and you put your age in and how many eggs you need for a 75% chance of getting pregnant or 80%. But if you look at the graphics on that, once you get out above 42, 43, they just don't have a lot of data, and it's hard to interpret. So I wish we had more information for those early 40 patients, but as Carolyn mentions, we know that maybe 1 in 4 eggs is good at 40. It could be 1 in 6 or 8 or 10 when you're 42 or 43.
Well, thank you everybody for really interesting questions. All the doctors are available to see you on video or in person, whatever you prefer. And here at SCRC, we put a lot of thought into each individual patient and help as much as we can. It's an honor to work with Dr. Danzer every day here. We high five in the hallway.
Thank you.
It's been a fun job helping people along the journey, and every question was really valuable to us. And so I hope we answered as many as we could today. Thank you so much